Thanks again for the opportunity to all of you and to the committee to present our proposal today. So the title is actually the ARISTON trial, so it has to be a perfect trial, which is why we present it, of course, in this forum. And so the whole title is the atherectomy and open repair for the common femoral artery atherosclerotic lesions. So as we all know, the PAD is a disease which is rising in the Western world and leads to numerous amputations and disabilities due to problems with the peripheral artery atherosclerosis, and especially lesions in the common femoral artery still constitute a very complex pathology, where primarily, especially in younger patients, surgical treatment is recommended as the gold standard.
Grigori, sorry, do you want to share some a PowerPoint or not?
I don't have a PowerPoint.
Okay.
Grigori, synopsis, you can show the synopsis.
Yes, I could do that.
Share the synopsis. Because we have also some drawing, also some images for the common femoral. Yeah, exactly.
You can see that, right? As I already mentioned, surgical treatment is nowadays the standard reference technique for treating such complex lesions in the common femoral artery. But of course, as we all know, also our patient cohorts grow older, they have more comorbidities, so there is a lot of cases where we have to treat patients that are over 80 years old or even not so old but have significant comorbidities as advanced heart failure, for example. So in the let's say, when searching for alternative techniques, of course, in the common femoral artery, probably it's not enough to do like just a POBA or even a POBA and DCP, but since most of these lesions are strongly calcified, it would be desirable to have a sort of lesion preparation or debulking to treat such lesions, and probably we have initial data from several groups that directional or rotational atherectomy may be a way to go treating such lesions. So the primary objective of our proposal is to investigate the safety and effectiveness of endovascular or surgical revascularization techniques for the treatment of consecutive patients with CFI lesions, and to do that not in a randomized manner, but let's say in the context of a real-world registry. Patients will be included with claudication or resting pain due to common femoral artery stenosis or occlusion. And in addition, of course, we would like to summarize or to collect clinical outcomes in terms of improvements in Rutherford categories, and of course, patency, target lesion revascularization. All these things should be systematically analyzed. This should be a multi-center retrospective observational trials. We have defined the study periods as the last 6 or 7 years from now. And the requirements are that the patients, of course, are informed, or we have a waived informed consent for conducting this study. Patients have to be older than 18 years. We decided to include patients with Rutherford categories 2, 3, or 4, but of course this is also a thing of discussion for today. We also decided to include, of course, common femoral artery stenosis or occlusions. An inflow treatment is possible, so concomitant lesions in the iliacs ipsilaterally are possible and can be treated within the same procedure. Of course, we need to have either an angiography or, in patients that have surgical treatment, CT angiography in order to classify the lesions. And I will show you in a couple of minutes the classification that we would like to use in our study. And in addition, we decided that we would like to include lesions in the ipsilateral, or patients that have concomitant lesions in the ipsilateral femoral-popliteal axis, but not very complex lesions. So for the after the common femoral artery in the outflow, the patients will have to have at least one vessel outflow in the PTK vessels, and they may have task A or B lesions, but not very complex task C and D lesions. We have to have, we require a follow-up, of course, if possible by duplex, if not a clinical follow-up in terms of the Rutherford categorization. And here is the proposed scheme by Rabellino et al. So you see this is actually in conjunction of the earlier classifications for the CFA disease, which has sort of also has been influenced by the Azima classification, but we think that the advantage of this classification by Rabellino is the fact that it goes for anatomy, so it differentiates between the common femorally and the bifurcation. It also goes by stenosis versus occlusion, and it also differentiates between mild and heavy calcification. We would like to exclude patients with instant restenosis, patients that have a restenosis after surgical atherectomy, as I already mentioned, patients with ipsilateral very complex femoral-popliteal lesions, and of course patients that have thrombotic lesions would also be excluded, and also patients that have a very progressed disease, Rutherford categories 5 and 6, and our outcomes would be the target lesion revascularization, restenosis after intervention or surgery, peri-procedural mortality within the first month. Of course, complications is something we would like to stress and look very carefully to that, like pseudoaneurysm or bleeding requiring surgery or redo surgery, peripheral embolization, and of course also surgical complications as wound management complications, lymphuria, lymphocele, and especially when needing a redo operation. Of course, length of hospital stay is an issue. Clinical improvement defined as improvement of at least one Rutherford scale, and of course major cardiovascular events during hospital stay and afterwards. Probably we will stress on two predefined groups from the lesion side, which is bifurcation versus isolated common femoral artery lesions, and from the side of the patient characteristics, patients that are older or over 80 years old, or patients who are over 70 years old but have significant comorbidities, as for example heart failure or unstable cardiovascular disease. And of course, we will need to take care of standard statistics as usual. Kostas, you may have some something to.
Yeah, one point. Excellent. No, I think you gave a nice overview of the idea. What I would like to add also is we consider to include also cases which treated by shockwave balloon, not only atherectomy, in order to expand, let's say, the endovascular number of patients, because probably would be a difference in the sample size. And under this aspect, we can say with calcium modified techniques, including atherectomy and shockwave balloon. As you said, we're focusing on the differentiation based on the anatomy, so we can see if indeed involvement of bifurcation of the common femoral artery is probably beneficial to perform surgery. But in case of non-involvement, probably you can have some group of patients which the technique of endo technique performs very well. Also, the octogenarian point is a good point, and I think we can check the two options not from the let's say aspect of comparison, but from the aspect of identification of these indications which the one or the other technique performs equal. Yeah.
Okay. First of all, thanks a lot. I think that we all agree that common femoral is a very important topic, and we'll see it more and more in the near future. My concern in this kind of studies that the indication, as Kostas also mentioned, is very different. So the reason why we treat patients endovascularly for common femoral artery disease, for de novo lesions, is probably the high comorbidity or obesity or whatsoever, because there is no obvious reason to go, or the patient doesn't want an open repair. So because up to now there's no obvious reason to go for endo first in the common femoral. I think it's very difficult to find centers that primarily treat the groin with endo repair, right? And my concern.
When I make a comment on this, you see one center.
No, it's not the case that we treat primarily with endovascular techniques. But of course, as you already mentioned, is a selection bias, because patients that come to our center, they want to be treated endovascularly. So it's a point of decision making from the patient side.
Yeah, so from my point of view, I see a big selection bias in this kind of study, and it will be the same. And with the same indication, we have a running RCT, which has the same exclusion-inclusion criteria, the PESTO AFC. So from my point of view, I think that the groin is a very interesting topic, but I would focus on a different indication, which will not be evaluated in the framework of an RCT, because this might be interesting, but you have such a big selection bias that you can evaluate these patients only, at least my eyes, and we can discuss about it in the framework of a randomized controlled trial. So my suggestion would be to focus on the groin, compare open with endo, but for redo groin. So for restenosis of the groin after surgery, because this is something that will not be evaluated in any kind of prospective trials, and it's something that we don't have any data at all. So first of all, it's very interesting for the literature. Secondly, there is a big gap in the literature, and third, I think will be easily accepted in every journal if you run for a different indication. But this is what I think. So prior to sending your proposal, we start thinking about doing it the same as endovascular versus open for redo groin, and we already have an ethical approval. But it's just an idea. So if you want to, we could run the same trial, but focusing on the redo groin, and then we can even discuss if we include all kinds of treatment options, not only atherectomy plus DCB, but all kinds of endo, and go for best endo versus best open for redo groin. But these are just my thoughts. We can discuss about it.
Yeah.
I think this is a totally different study, Kostas, because I think it's very limited, the redo groin. From my side, this is a lesion I would never, I've never treated such a lesion myself before. I've never seen such a lesion after a groin. Perhaps they're seldom, but this is also, I think, a bias, because the patient goes back to the center usually that is treated the groin surgically. This would be interesting from a surgical point of view, but I think for me personally, as an endovascular cardiologist, I don't have these patients to contribute. I think this is an interesting point, but I think it's a much more limited number of patients that you have for this sort of question.
I don't know also the definition of redo groin. Redo groin due to wound complications, redo groin due to occlusion.
No, redo groin, restenosis of the groin after surgery.
Yeah.
Yeah.
But I think everybody will prepare primarily endovascular to treat this case, then or surgically. Surgically, we treat only if it's no option for endo. So
interestingly, if you talk with the centers, it's not the case. But anyhow,
this is another. What I think we have in the introduction of the synopsis, the pesto. Can you show us? And we knew that probably this would be a very good point remark from the reviewers. Which is the difference? Why should we focus on this registry and not on a randomized trial like the pesto? And I think we comment on this in the introduction that based on the inclusion criteria of the pesto, I think they have completely different. What I think is new is that we want not to compare apples with oranges, and we want to have this nice classification in order to identify exactly which segment is a beneficial segment for open or when we have more events when we're treating by endo repair. I think this is not present in the pesto. So we have let's say more, even if it is a registry, not in general common femoral artery, but you have is involvement of the external, is involved the bifurcation. And this is, I think, very nice and unique. And it will differentiate the procedure, I think. And okay, redo, as I said, I think is of course interesting, but we don't want to, because redo means you have per se higher risk for surgical complication if I'm reopening an already surgical treated groin. So I would expect to have more events. The question is, and therefore you see that in our endpoints, we didn't say a hematoma or some wound, I don't know, minor issue, but we say always needed reintervention or surgery. I mean, I think this is nice because it's a completely new groin, you know, you don't have per se complication. But if I have now a second, third operation after previous surgery, probably I will have more risk for events. And at the end, probably we will identify that probably endo is better or is short beneficial, avoiding local complications. So I don't see the clinical benefit of something like this per se, especially because I think for the majority of the centers, endo repair would be the first option. What you said about the selection bias is a good point. The primary idea was to say methodologically in the center from Grigoris, they are treating endo issues like this, and we are treating surgery. So we had the idea to say we have per se methodologically consecutive patients due to the philosophy of our centers, due to the strategy of our center. But then we realized that, of course, we can compare our numbers and see this, but I think per a registry, we have more power. And then we consider, to see these points. And of course, we can have this limitation in the article, and we can say that there is per se a selection bias. We can report on this in the study, but the main question is if you see the potential, and also Naso, your opinion is also important to give us a feedback, and if you would like to support the idea, I think this idea.
I think Isabel has a question.
Yeah, I had a couple of questions. First of all, I think it's a great study. I kind of agree with Konstantinos. It will be very difficult to conclude anything because of the selection bias. But you're also saying that you will not collect hematoma or small things. I would be careful there because they may actually lead to an infection in the long run. Secondly, you say I'm not going to take anything into account that is not surgery. So what are you going to do with VAC? If people put VACs on groins if there's an issue there, because that may also lead to more problems afterwards. And then last but not least, I think what I would be worried about is how many cases would you need to draw any conclusions? Because you will get a huge variety of patients with different treatment modalities. Is that correct? Because, you know, there's also the Super Search trial currently running, the randomized controlled trial from Koen de Loze in Poland, the Netherlands, and in Belgium, focusing on common femoral artery disease, where they do ARTERECTOmy versus Supera.
Let's start one by one the questions. You asked about hematoma. The first point was hematoma or surgery. No? So this is a retrospective study. This is not a prospective study. This is a retrospective study. And my first consideration is how profoundly will be the documentation to detect each hematoma, which be observed. Secondly, what is the clinical relevance of a local hematoma which disappeared? Actually,
I'm not talking about small hematoma. There's definitions for that are standardized, that lead to an increased length of stay, and that's considered as a major adverse event.
Yeah, but we have VAC and
VAC is included. Yeah,
is included. We have it. We don't say only pseudoaneurysm or something. You know, we have VAC in the parameters. So all these parameters, VAC, as I said, bleeding, needed surgery, pseudoaneurysm, all these points are were presented by Greg. So the second point regarding the, you said how many patients. So
yeah, the number of patients you would like to have.
Yeah, exactly. This is a good point. And therefore, we wanted to have this analysis based on the localization of the lesion. So we will see how many patients have, let's say, separate segment, common femoral bifurcation included, external involvement based on this, I don't know the name, Rufino, how is the name? So, yeah, we can, which is the evidence? We need some evidence in order to find the absolute numbers, no, of needed.
I think for both Costas, the attractivity in the trial is, I mean, you have the proposal for random stop, where we're also working on. And I think that many patients included in randomized trial are very, very selected. So there you also have sort of a selection bias. And I think that we will not see the results of the FESTO until probably in 2 years from now or in 1 year from now. And our aim would be to conduct sort of a more real-world trial where we include probably a larger number of patients, and we are not only limited to a comparison. That's why we do not say we compare the two arms. It's just sort of an objective report in the two arms. If we have enough patients in order to do some matching, for example, based on the lesion characteristics, then we could do sort of retrospective matched post hoc analysis. But our primary aim is not to compare, it's just to report on the contemporary, let's say, treatment options for the common femoral artery within the RCPID registry. Yes, go ahead.
Your third question was, Isabella, what was the third question?
No, the last question was just that, you know, there's also the randomized controlled trial here in the Netherlands and Belgium of the Loze, where they do Supera versus open. I know it's slightly different, but that will also be more standardized. And of course, also not the real life features, like you say.
But, you know, it's completely different. You know, retrospectively, it's difficult to compare. But when are going to come the results, etc., you know. Naso, from your point?
Sorry, am I muted? No. I've got a number of thoughts, actually. I think, well, the reason why you're presenting here, but we all agree that this needs doing, okay? And fortunately or unfortunately, we do quite a few endovascular groins. I can tell you that for the UK, you'll probably get couple of centers where people don't get a stroke once you tell them that you've treated a common femoral with endovascular means, even for recurrent disease. And these centers would be Leicester and St. Thomas's. But again, you're not looking at hundreds of patients. It's a few dozens of patients primarily treated with endovascular means if you've got isolated common femoral artery disease. At the same time, we can definitely find these patients and take part in your study because we think it is important to do it. The one problem we've recently had with a similar study looking at popliteal arteries, and where I've personally really struggled, was the fact that we had a number of completely different treatment approaches. And then how do you compare things? Because it's impossible to enter all of these different treatments into a regression model. So let's say we end up with 150 groins or 150 arteries being treated primarily with endovascular means, and we've got 5 different treatments. It is simply impossible to make any form of conclusions, really, as to which treatment is slightly better. So you practically end up having a very descriptive study, a cross-sectional study, where you're only looking at numbers or proportions of complications after each treatment, but there's just no point including p-values in order to compare those treatments. So then we need a discussion as to how we group together all of these different treatments, especially if we start including IVL. So I think I'm not phrasing a question here. I'm just trying to express my thoughts, because I think if we just do this, including every single treatment strategy, we're going to have the exact same problems that we've had with our popliteal study, where we had something like 8 different treatment modalities for a few hundreds of patients. And then I just don't know how I'm going to compare things. So the one point from me, shall we have a thought, shall we have a think about how we group together those different treatment modalities, if you like? That's all I had to say. I definitely think that it needs doing. I wouldn't worry about the ongoing RCTs, because these RCTs, they've got lots of flaws and they're not effectiveness trials. So looking at patency anyway, so I'm not sure how we're going to incorporate these into clinical care.
If you consider the treatment options for the groin, I'm thinking atherectomy plus DCB, one option. The second option would be IVL plus DCB. Probably you and Kostas have the largest experience and cases. And the third would be probably, and this is now the big point, as you said, we can include as exclusion criterion, stenting is excluded, for instance, or we can say, no, yeah, Grigori, we can include, I'm saying only, to minimize the range. I think it's a great comment, to minimize the range of the options. But, or we can say, with additional stenting, because sometimes you have suboptimal outcomes, and a lot of endovascular colleagues are putting superas. And I have one case tomorrow in which in one patient, it has a supera in the profound femoral artery, and it is, the orifice is of course above the bifurcation, so above the orifice of the profunda. And the great thing is he has a high-grade stenosis in the proximal segment of the stent, adding it's open, but it is 80 degrees of stenosis exactly at the orifice, and the patient gets the best thing, has a previous open aorto bifemoral repair, so it's groin, previous groin also. No, I mean, what I mean is we can include also plus stenting, but I think compared to the popliteal, you don't have so many options in the groin. I think atherectomy DCB, IVL DCB plus stenting in case of dissections and recoils. What do you think?
Exactly. I think this is an excellent point from Thanos. The problem probably in the popliteal was that there was a sammelsurium of treatment options that were compared to each other. But we know for the groin that POP or DCB alone is not an option. There is data that the preventive patency is extremely poor if you just do ballooning. So what we would accept is exactly what Kostas just mentioned. Atherectomy plus DCB plus minus bailout stenting. We can talk about the IVL. I'm not sure if we have to include that or not. This is we can see how many patients we get with IVL, and then probably discuss about that.
Okay.
We include such patients. But I would say if we want both, then I think there's not many centers that do atherectomy and IVL and DCB due to reimbursement issues. So it has to be either atherectomy or IVL, I would say.
Yeah, or only atherectomy. So we consider IVL only to increase the sample size, but we can leave it as only atherectomy, DCB, plus minus stenting.
Kostas, you had another question.
So, from my point of view, when we, as I said, when we plan a trial, we have to see the gaps in the literature and see why we need this kind of trial, right? So, if we, I mean, it's okay, we can run a trial or a retrospective analysis of this kind of data, but I would do two things. First of all, I think that what we need is best endo versus best surgical. So I would include all treatment options, and then I would perform an analysis endo versus open, because this is what happens in the reality. And you say, Grigori, that we know that PTA is not an option, but you will be surprised how many people perform PTA. And I think this is another selection bias from our side to compare the best, only the best endovascular treatment option, where we see that in the reality there are so many people doing various stuff.
Okay.
So and the problem is from the randomized trials, not only the indications, of course, but also that they evaluate just a single modality. Either it's Supera or IVL or atherectomy plus DCB whatsoever. So from my point of view, what we need is like the best CLI, a trial comparing best endo versus best open.
But
because you cannot say that when I perform an open repair of the groin, I will exclude automatically all patients requiring an interposition graft. So because this is something that can happen when you do a common femoral artery disease and has not so good outcomes than atherectomy. So I think that going for a best endo versus best open, it will be something that we need in the literature. Secondly, I would expand the exclusion-inclusion criteria. So include patients with occlude SFA, include patients with Rutherford 5 and 6, redo groins, etc. Because this is what the randomized trials means. I mean, we can discuss about it, but I think that going for a trial best endo versus best open, and then including all patients makes sense. But just focusing on a single indication with the same inclusion-exclusion criteria like a randomized trial, I think it's questionable what this study is going to offer.
Yeah, we consider all these points. My first point is, what is the definition of best endo best? I don't know exactly.
Best is what the interventionalist did during the procedure. This is the best. This is the definition of best. Why it's if you don't want to call it best, you can call it just endo, endo versus open.
Yeah, but then you can have the Samelsurium, which you have in the popliteal registry, in which you say at the end angioplast, you should do something.
That's true, but in the popliteal registry, we were trying to compare endovascular modalities with each other. Now we want to compare endo versus open.
Yeah, but at the end, what was the endo procedure? Then if you have too many endo procedure, you can say the endo is better or less, because you have, as Thanos said, 5-6 endo options. And at the end, you can present it as one endo procedure because you have 5-6 different options. And this
but you cannot treat all lesions with the same modality, first of all. Secondly, this is the problem of endo, that you have so many modalities without clear definition and without clear indications. And
but if we have, let's say, one option, which would be, for example, atherectomy and DCB, we can say exactly that. We can say that endo is better or less compared to surgery. We can say only atherectomy and DCB is better or less, which gives more, let's say, power, because we have one. We can say in general, but we know more something about one, because then you can have the problem of saying as in the popliteal conclusion, angioplasty do something better than angioplasty. So, but you know, there are pros and cons. As Stanos said, if you have too many options, I think the idea was to minimize this kind of mixture. You know, we're gonna have mixture of, let's say, options, and if we have too many parameters, could be the conclusion, but I understand your point, could be the conclusion not so powerful. Regarding the inclusion of many complex lesions, this is exactly what we consider to avoid. Why? Because if you have too many complex lesions, SFA, poplite, etc., then you can expect from a groin operation, surgical operation, to improve, let's say, something which is so complicated. You will need a bypass, you will need something more, let's say, invasive, or you are not going to do only atherectomy or DCB or something in the groin. You have to treat the popliteal, you have to treat the crural, and then you are not going to go, which is now the impact of the groin treatment if I have 200 additional treatments in the distal segments of the vessels. And by this, we will minimize the impact of the groin treatment. And therefore, we consider, at the beginning, we had, as you said, everything together, but therefore we consider to avoid it in order to focus on the impact. And therefore, in the inclusion criteria, we have only claudicants and rest pain patients and not CTLI patients, because they will have per se multisegmental disease. And we don't have a robust conclusion of the impact of the groin treatment. Therefore, we didn't include them.
I agree with what you said, Donas, with the inclusion criteria, to keep them that strict. I would also be worried that if you put too many CLI patients in, that you have to do extensive FEMPOP and even below. But what you could do to solve the discussion here, because I'm kind of, Tanis, of course, is right. If you have to interpret the data and we have too many techniques, it will be very challenging. But what's always important from a reviewer's point is that if you say, okay, for us, the ideal treatment is atherectomy, drug-eluting balloon, and if necessary, a stent as a bailout, you will also just gather the other data as well, so you can at least tell what people are still offering, what other modalities they're offering, without the goal to compare them with it. Because then you know what's happening in the real life, because that's what Konstantinos wants to know. He wants to know what's out there, what do people do. Gonna be very honest, in Belgium, we hardly do atherectomy because it's not reimbursed. So we are the ones who just do PTA.
One problem which I have seen about these treatment options is, for example, the definition of success in the groin if you treat a stenosis with PTA. So,
fully agree.
So
but if you make it mandatory that you have a duplex scan afterwards, then at least you have something to see.
But also, what should I detect? 0.5 decrease of the velocity. Nobody's going to do this. And the problem is, if you do, for example, PTA, you have a patent vessel before, you have a patent vessel afterwards. So at the end, you don't have any significant impact on the patency. Therefore,
no, but I'm not saying that you have to do that. I was just an example. But even if you say there's other modalities that we would like to capture, you could collect it, what is happening out there, but only focus on that specific ideal treatment that you regard. That is the atherectomy.
Let me ask you more realistic. You know better the groups, etc. How many centers, based on your experience, Costa, Isabella, and Thanos, from your big registry group, would go for isolated PTA? How many for atherectomy? So, or something additionally? Do you think the majority would treat by atherectomy or and additionally balloon angioplasty, so something more? Because
may I ask something? Because I think we said that the primary goal of this study is to describe and not compare. If the aim is to describe, why don't we include all kinds of treatment options? Because then we'll describe what people are doing. And
good point. Very good point. Because then we don't have to go into this funny business we had with the popliteal project.
We can add Costa also POBA, and you mean, what are the other options? Primary POBA or what?
What we could also do in order to, let's say, differentiate our trial from the pesto is, oh, perhaps he can give us some answers, right?
He's more hardcore than I am.
We will have him co-author.
He will be a first and last author together. We could, I think Kostas will discuss that already. My notion was also to include Rutherford 5, but not Rutherford 6 patients. This way, we will not have the real sick ones with big necrosis and gangrene, but we will get a way to differentiate our trial from the randomized trial. On the other hand, I would perhaps we should not include very complex lesions in the femoral popliteal axis.
And I think
because this is another different problem, which you already explained.
No, I mean the treatment options which we have. Which are the endo treatment options? So PTA.
What I meant before is that when you look at the inclusion-exclusion criteria of the pesto, for example, they say that if the lesion extends in the SFA, the patient will be excluded. So which means that if you don't have a patent SFA, you cannot treat this patient. I'm saying that we can only focus on common femoral artery and the proximal branches procedures, even if just a profunda revascularization. That's what I meant. And the same is for supersurge. So I think that if our aim is to describe what's going on, I would include everything. And then we can, because this will increase also the number of patients. Because I really cannot answer your question what the centers do for common femoral artery disease. I know that Grigoris does atherectomy plus DCB. I'm doing sometimes atherectomy plus DCB, sometimes Supera, sometimes Shockwave plus DCB. But at the end of the day, it's such an inhomogeneous situation that right now we don't have a clue what the people do for common femoral disease. So if we want to describe and not to compare, I would suggest to include everything. And then we say this is the reality of common femoral artery. And then depending on the number of patients that can be included, we can say in this indication have benefit or not or whatsoever.
The only problem is if we include everything, we will be, a mixture of thousands of data, and I'm afraid to have something like Thanos presented. We have included here the SFA TESC A and B coexisting lesions, exactly as difference with pesto, but also in order to give the possibility to treat, let's say, additionally something in the SFA without a significant impact. But we included exactly for this reason, TASC A and B lesions of the SFA should also be treated, or can be also treated, But as I said, it is only one click, we can put additionally points and then see how the centers reacting. At the end of the day, I think if we want to have a robust conclusion, probably we will need somehow more exclusion of different parameters which will influence the conclusion. But yeah,
we even do two papers.
We can include the endo option, leave it open. We can say PTA, stenting, atherectomy, blah blah blah, in order to find this best, let's say the best endo as possible.
If we create a big database about common femoral artery, right, then we can publish a number of papers.
Yes, exactly.
Yeah. So I suggest, in order to be, everybody will be happy, to have a very broad data collection, include all kinds of treatment options, all kinds of indications, and then we can, then you can go for a big common femoral artery registry, and afterwards we can perform many kinds of analysis for redo groin, for bypass anastomosis stenosis, for CLI versus claudicants, for atherectomy plus DCB versus surgery, even for different treatment options whatsoever. So I think that the best thing to do is to create a big CFA database.
We could do like this. We could have in the Excel table all these parameters, but redo, yes, no, 1, 2, 1, 2, and we know what we want. So But as Costa, if someone present now the redo case included, then you can select this, and Kostas can publish the redo cases. You know, it is not, and we can, Grigori, focus on our, let's say, endpoints and say, from this database, we, let's say, 70% give us this information. Okay, 20% gives the information which Kostas wants. Okay, I think the idea of including many things in the table and then select based on our scientific questions is a great point, and should do it, from my point of view.
I think also it will be like Pericles, you know?
Yeah, something like that.
And then identify subgroups and everything that you need to publish many papers.
Yeah, it's a fantastic point. And I think we can have more data about CFI, so why not? So my suggestion is, because I'm happy that you agree, to leave Grigori's the preparation of the Excel table, send to you to add your points, etc. Kostas, some additional issues, for example, but Grigori's added the aspect that we want more data, we want also redo cases, we want this and this and this, also more options, and then we can send to the centers. What do you think? Thano? Yeah.
Yeah, I completely agree. We're practically now creating a registry.
Yes.
And then, you can practically take the registry and create decent descriptive or observational data rather than go into the same business as we did with the popliteal project. I couldn't agree more, because then it's real world, and no, I agree with you guys. Yeah.
Okay, fantastic.
Perfect. Yeah.
Good.
But then it would be better, you know, if you just change the proposal a little bit to CFA registry. I can help you. Want to? I can send you also the things that will be prepared for the redo things. And then you know, we can come with a proposal, send to all centers, and say we'll go for CFA registry. Will represent the reality. And then if the centers have a specific question, they can also, you know, we can produce many papers like Kostas Donas did with Pericles for Chimba.
One paper per week would be the...
Yeah, sure. You know, there are some indications, like we say that everybody will go for endo for redo growing, but there is no data in the literature showing that endo has a benefit, or that we should do endo for redo, or any kind of publication for redo growing, or bypass anastomosis stenosis. None. So that's why I'm saying that if we send this application to the centers and ask them to collect data, it would be better to include all kinds of CFA disease. Probably it would be better to shorten the time, the last 2 years, because otherwise, we're looking for 10,000 patients, and then but then publish more papers in this topic.
So in that case, just for me to understand, when conducting the table preparation, so we would like also to include cases in terms of surgery or endovascular treatment that have treated concomitantly, for example, groin and bypass, or endovascular in the...
No, I think you don't have to say...
Why not?
Best your treatment option, you know, as Kostas said.
Yeah, but we're talking about the indication. You can also include bypass anastomosis.
No, I know. Yes, this is no problem. But what if a patient receives a groin, a atherectomy, and a femoral crural bypass?
This is
also a patient in... No, this is not. Okay.
No, this is a long. I think in our proposal
we might add hybrid procedures.
Okay.
So if I can summarize, we will go with Greg with our proposal as we have it, Greg. We will publish this, but we will ask them. So we will expand the registry, and we can include, as we said, the other end options, plus the other end options, and the redo. So you can see our exclusion criteria. You can include them. You know, we don't have to say the ARISTON trial. You can say CFA registry. Basta.
Exactly. Kostas, let us collect data about all indications and treatment options. Not, everything. Even rather for class 5, 6, whatsoever, and then we can, clean the database and proceed.
We can do it like this without to say, but we can say that we will focus on this, let's say, as we have it now as ARISTO trial, in order to avoid to make, because we say, okay, what is exactly the goal? How should be the publications? Who is going to publish? You know how they are thinking sometimes. What we want to say is we can send something as CFA registry. We can put everything there, but we can provide this information that we want to focus only on this if necessary. If not, you know this, we know this, it's okay. For example.
So we all agree, because Thanos has to leave. Isabel, do you have any additional questions or remarks?
No, I think it's clear now. Real life capture of what's happening, and then we analyze it. And we already know a little bit what the goal is for the study of donuts, and then we extract extra data for other stuff.
Excellent.
Okay. Thanos, any other remark?
Yeah, completely agree. I quite like registries because there's a place for RCTs, there's a place for very bad RCTs, and there's a place for good registries. So I think if we create a decent registry, we can get lots of information out of it.
Okay. So how do you want to proceed? When do you want to, should we meet again in a month or something to discuss again, or do you want to send a proposal and then?
Yeah, I think we will send, Greg, what do you think? We can send.
The best way is I would try to prepare an Excel spreadsheet, and I would circulate it to the people that attend this meeting, and everybody can adjust it or add some areas that he has or she has wants additionally, and then probably it would be good if we have the final spreadsheet within the next month, I would say.
And I will modify our proposal, saying that CFI registry, Saradzi, Stavroulakis, Korosoglou, Isabella, Dona's proposal to have everything as, let's say, idea, and send it to you, and then you can circulate internally or add or modify it as you like.
Excellent. Okay, nice.
Let's see, in the next 2-3 weeks, you're going to take both things.
Okay.
Okay.
Have a nice evening.
Thank you, guys. Bye-bye.
Thank you, everyone. Very nice seeing you.
Enjoy. Bye.
Take care. Bye-bye.